Welcome to Medcastplus show. My name is Helen Bays, and thank you so much for joining us today. For this show, I will feature a key opinion leader who serves our community and an expert in irritable bowel disease as well as irritable bowel syndrome. He really understands the difference between the two. Dr. Brun's experience clinically, professionally, educationally, as well as surgically is really unique. So now we as a community can become an area of powerful influence and knowledge. I invite you to get involved as an individual as well as a community so we can all become experts and very savvy and tightly connected to make the difference we all need. My guest here today is Dr. Alexander Brun. He's a physician in Triboard Gastroenterology Group. He practices in Brooklyn, Staten Island, and Bronx, affiliated with Mount Sinai Health Systems, graduated from Northwell, as well as conducting various research in various different disease states and published a lot of studies. Now it's my greatest pleasure to introduce to you Dr. Brun, who will share a little bit of his background with you.
Thank you, Helen. That was very beautiful words you have said. So it's true, I'm a gastroenterologist. We're based mainly in South Brooklyn, and we do have a new location in Staten Island and in the Bronx. We are part of a 5-person gastroenterology group with myself, Dr. Grossman, Dr. Pratik, Dr. Chen, and Dr. Payson, who's going to be joining us in September. We do specialize in a wide range of gastrointestinal diseases, spanning from acid reflux to screening colonoscopies, and we're capable of doing almost any procedure available today in gastroenterology, including ERCP, PEG, colonoscopy, and endoscopy. I myself do have a big passion for inflammatory bowel disease, and which tends to overlap with irritable bowel syndrome. I do currently live in Brooklyn with 2 kids. Wife is pregnant currently.
Congratulations.
Thank you.
Is it boys, girls?
It's all girls.
Okay, and hopefully they have no IBD or IBS. To actually ask you, I've heard recently that you have some research that you're doing with a capsule that you actually swallow, and then it shows everything on the screen. Is that something you're really studying in the office?
Correct. We are. There's multiple capsules available, but the ones that we're involved in today are Bravo capsules, and those are capsules that tend to be for patients more with acid reflux symptoms. And those are patients that basically come in for you and say, I have heartburn, and you treat them with the common medications from whether it's Dexilant or Nexium, but they're not getting better. So then you wonder to yourself, well, what is it? Is it because you're treating, it's not enough, or maybe you're treating the wrong thing? So then you put a monitor or a capsule into their food pipe. You could do it endoscopically, meaning through a camera that looks into their food pipe, and you place it there, and they hold it there anywhere from 72 to 96 hours, and then it'll tell you when they have symptoms. Is it because it's acid reflux, or maybe it's bile reflux, or maybe it's just a spasm of their food pipe? And the other capsule that we tend to do in our office is for patients that, let's say, have gastrointestinal bleeding. These are very unique capsules. These are camera pills. And basically, these are pills that will take thousands of pictures of your gastrointestinal tract, from your stomach to your small intestine to your colon. And then we sit there, and however long it takes, and we evaluate each picture individually, and we find the cause of the bleeding, and then we can go after it. So if you have a very kind of a cold bleeding in the terms that nobody could find it, they've already looked in your stomach, they've looked in your colon, we'll give them this capsule, and once we find that source, then we'll go after it.
That's impressive. So it's less infection causing.
Right, and it's less invasive, and it's very easy to do, and honestly, and it prevents side effects from extra unnecessary procedures.
So the big question we've all been waiting for is, how do you differentiate IBS and IBD?
And I'll tell you the truth, it's a tough question, even for gastroenterologists, because the symptoms of the two tend to overlap. With IBD, when you think of IBD, people think of Crohn's disease, they think of ulcerative colitis. Those are truly, chronic conditions that tend to go in waves from its peaks where people are feeling terrible to kind of the low point where they may be well controlled. And IBD is a condition it's basically an autoimmune disease of your GI tract. Your immune system, for whatever reason, didn't understand something or got confused and assumes that your GI tract is not part of you, and it attacks it. And that could be anywhere from your stomach to your colon to your small intestine. And it'll irritate it, and it could cause ulcers, and it could cause bleeding. And you could imagine that's very life-changing, and these patients end up suffering without proper treatment. And we end up treating them mostly by, one, understanding it, and then suppressing partly the immune system to make them feel better. Well, on the other spectrum, you have IBS. These patients come in with you, they also have pain, they have diarrhea, they could have constipation, they could have nausea, very similar symptoms. However, you've done most of the tests, including you've checked their stomach through an endoscopy, you've checked their colon through a colonoscopy, and none of these tests hurt, by the way. You're completely rested and sleeping when you have it. And you don't find a root cause, meaning you don't see any true mechanical damage. And when that's the issue, that's a little different. On the one hand, yes, that's better, but on the other hand, well, what's wrong? And those are the people that you think about when you think of irritable bowel syndrome. These are the people that tend to have, as people say, oh, your nervous system, your GI tract is a little off. But it's not that it's off, it's that it could be hypersensitive, meaning that I eat a little bit, you eat a little bit, I feel discomfort, you do not.
Oh, I do. Okay. So basically one's a syndrome, one is a disease.
In one way, correct, one way of looking at it. And the other way that's interesting to look at, and this is becoming more and more what we're thinking about, is that the gut flora can be off. Meaning the bacteria, the communal bacteria that serves to benefit us and we benefit them, that lives in us, can become imbalanced. And when that happens, basically you create unnecessary gas. And your GI tract doesn't feel, cuts. You could basically, I could take a sample of it and you won't feel it. But it does feel distension, it feels the gas. And that's why most people, they come to us and they're like, oh, I'm so bloated, I'm so distended, I'm uncomfortable. And that's what we think about when we think of irritable bowel syndrome.
So what's a typical patient type that you would see coming in presenting with those symptoms?
Well, the patients that present with these symptoms, they range. In reality, yes. So irritable bowel syndrome, it tends to occur more in the younger population, usually in their 20s to 30s. These are people that are active. These are people that are high strung. These are people that, that have a lot of things going on, whether it's family life, young children, they're trying to new career choices. And these patients are completely healthy. They're coming in, their blood work is normal, they're not on any medication. And these are the people that you think of when you think of irritable bowel syndrome. On the other hand, you have your inflammatory bowel disease patient. This tends to have two peaks. You think of the 20-year-old that's coming in with severe pain, weight loss. They may notice blood in their stool. And, those are all red marks. You start thinking...
Is it light blood or dark blood? Because they always ask.
It's a good question, actually. And this requires a little bit of research, because dark blood is, you think of the upper GI tract, stomach bleeding, because the red blood cells, they get broken up as they go through your stomach, the small intestine. By the time they reach their colon, what's inside of them, which is the hematine, the bilirubin, turns dark. So your stool turns dark. Even, by the way, a drop of blood will make your stool black. While bright red blood, you think of lower gastrointestinal symptoms. And that's very helpful, because things like ulcerative colitis, which is part of inflammatory bowel disease, will have red blood because the colitis is near the end. So that's fresh blood coming out. And that will basically point to us, okay, well, that's where we need to look. And while, yes, dark, you think of, oh, maybe this patient has an ulcer. And yes, it requires a little bit of an educated patient to kind of point us into that direction, and but it's very, very, very helpful.
Do you think those emojis help now that they launched with the poop? You could send it to the doctor.
And by the way, we do get all types of messages, and those emojis would be helpful and funny. In our group specifically, we're a young group. We're very friendly with our patients. A lot of patients do have a very easy, direct contact with the doctor, whether it's to text us through our office phones or email us. We are easily accessible. Maybe too easy, maybe you're right.
I mean, I could contact them on vacation.
It's true. And with emoji of the stool. But yes, all those are very helpful. And the truth is, we have these discussions, and some people go like, "Oh my God, a gastroenterologist? Why did you go into this field? You have to look at stool." But on the other hand, that's a big deal. That's a big quality of life, and that is always one of my questions. Okay, how do you describe your stool? Is it too soft, too hard? Is it in pieces? And it does tell us a lot about that patient, whether it's his stool is not being formed because of his bowel flora is off, or because the stool is too formed because he has slow kind of transit.
So what do you do?
Well, so you have your diagnosis. So let's say you have your diagnosis of inflammatory bowel disease, and then you have to kind of put them on a spectrum. Is it mild? Is it intermediate? Is it severe? Because the medications are all kind of, they're helpful, but medications are medications, and each medication could have its own repercussions. So while mild disease, we could do very, very little. We put them on a very superficial immunosuppressant, such as Preza or Pentasa. And the patients are on a medication that has almost minimal side effects, and they're feeling well. They take it once a day. They have no complaints. They come to us maybe once every 3 to 6 months, and then we end up doing a colonoscopy for screening for cancer once a year, but they live a completely normal life. While you have the more severe disease, where those patients we do tend to put, this is for Crohn's or ulcerative colitis, and whether it's subcutaneous injections or intravenous medications such as Humira or Simponi. And these are the medications that are molecular, or as they call biologic immunosuppressants. And these patients tend to be on treatment, let's say every 2 weeks to every 4 weeks, and that does also ends up controlling their symptoms very well. The side effects are still minimal, and yes, they follow up more common, maybe once a month, maybe once every 3 months, but we could get them to live a completely normal life and with almost minimal to no symptoms.
Would it be easier if it was pills, like Celgin? I think just Pfizer launched, yeah.
Agreed. Pills are much easier in the sense to take, and we have to speak to the patient, because you have your, very responsible adult who is going to take a pill every day, and then you have, maybe a high school kid who's thinking of going on dates and partying, and he may not remember to take the medication every day. Mm-hmm. So that's part of how you think about it. Another thing is, well, what's your preference? Do you mind taking a little shot every 2 weeks, or would you rather take a medication every day?
Is it infusions or just injectables?
It's a combination, actually. You have your infusions, which are Remicade, and you tend to have to go to an infusion center, but those seem to be are less frequent medications. And then you have your injections, which is basically Humira. And those tend to be every 2 weeks. Sometimes if a patient is not well controlled, you could lower it. You could do every 1 week. And there are certain tests that are today, technology is amazing. These are medications that are basically antibodies to your immune system. But we could actually measure whether the levels of these medications, we could measure whether your own body is creating antibodies to, let's say, Humira or Remicade. And that's how we could determine, well, is it working, is it not working? And then we could either up the dose or change it. Well, this was never available in the past. So we could really get these patients under good control.
And do the patients have to pay a lot more, or the pharmacies adjust it?
Actually,